Hello and welcome to the second webinar of the three-part TelePET webinar series on teaching endoscopy. Today's meeting will focus on the use of simulators to enhance training. We are happy to be sponsored by Steris for this webinar series. I would like to now introduce one of your course co-directors, Dr. Shivakumar Vignesh.
Good morning, everybody. I'm excited to welcome you all again to our second webinar. And this is in the series of webinars on teaching endoscopy. Today's topic will be how to best use simulators to enhance endoscopy training. And again, I'm excited to work with Dr. Catherine Walsh and Dr. John Cohen. And today, Dr. Roy Sutikno will be joining us. So here's all the faculty for today's program. Next slide, please. So for those of you who already attended our first webinar, we had discussed a framework for enhancing training. Today, we'll focus on how to best use simulators to enhance training. And later, we're going to have a session on feedback and assessment for learning. And there's a QR code. The objectives for today's webinar are how to explain how to select a simulator for endoscopy training and identify best practices in endoscopy simulation-based education, and then describe the mastery-based approach to endoscopy simulation training. And lastly, discuss the use of simulators for remote endoscopy training. Next slide, please. So some basic housekeeping issues. Please mute your microphone during the lectures. And when the time comes for a panel discussion, please name yourself on Zoom so we know who's asking the question and for attendance. The raise hand function will be disabled. So we ask that you type your question in the Q&A box and I'll ask them during the panel discussion at the end. And after the session, please complete the feedback survey. At the end of the presentation, you'll have a QR or a link for the survey, and we really value your feedback. So the program today will have 2 lectures, each for 20 minutes, followed by a 20-minute panel discussion, and the total duration will be 1 hour. Next slide, please. So now I'll hand over the microphone to Dr. Walsh, who'll be giving us an overview of how to best use and select simulators to enhance endoscopy training. Thank you. Thank you, Catherine.
Thanks so much for the kind introduction, and it's a pleasure to be here speaking today on simulator selection and best practices in endoscopy simulation-based training. So in terms of simulation is an instructional methodology that really tries to engage learners in lifelike experiences, and it's designed to mimic real-life encounters. But you have to remember that simulation in of itself is not education. Simulation is merely a tool that enables education. So simply providing trainees or practicing endoscopists with access to simulators does not guarantee that they will learn. To be effective, simulation really needs to be integrated into training in a thoughtful and deliberate manner, and really grounded in educational theory and evidence so that we maximize its effects in how it can help people to learn. And in thinking about endoscopy, there's a huge range of kind of teaching methods that you can use to teach endoscopy, and simulation can be integrated into many of these. This is just a basic learning curve, and for anybody learning a new kind of clinical skill, simulation-based training is often becoming an integral part, especially early in training or in learning new skills, as it allows people to really practice in a safe environment without putting patients at risk. And in looking at this picture, one can see that in general, trainees improve with practice. And simulation alone does not create experts, as I mentioned. It provides a means for trainees to practice their skills in a safe environment prior to performing the procedures on patients. And as depicted here, simulation really allows an individual's performance to move along the learning curve so that they're more proficient at the time of their first patient exposure. And this is really for more novice endoscopists. But simulation is increasingly being used not only for novices, but also for more advanced trainees, as well as practicing endoscopists. And it's not only for technical skills related to endoscopy, such as scope handling or loop reduction or polypectomy. It's also for things related to cognitive skills, so lesion recognition skills, as well as non-technical skills, so things like teamwork and communication. And we can really use simulation across all of the skills that encompass endoscopy competence. The use of simulation dates back before the Middle Ages, where they would create kind of models of patients that were built of clay and stone, and they would use these to demonstrate clinical features of disease and their effects on humans. And with regard to endoscopy, it really kind of gained momentum in the 1960s, and more recently, as technology has advanced, simulation has become more integral to training. Most of the studies in the past have merely asked, do you like the simulation? And garnered people's perceptions of simulation. But this is really akin to asking somebody when they're getting a massage, did the massage feel good? It doesn't mean that it actually worked. So to maximize learning, it's really essential that we study simulation systematically and that we develop evidence on how best to integrate it into a curriculum. There's been a number of systematic reviews done that have demonstrated the effectiveness of endoscopy simulation-based training for primarily novice endoscopists to promote acquisition of skill and improve their performance of initial procedures, and also to accelerate their learning of the skills. And as I mentioned, there's also some evidence that it can be used for training of non-technical skills. So one of the first questions we have to ask is, how do we go about choosing which simulators to use? In thinking of endoscopy-based training, there's a whole host of different simulators. So for example, there's very lower fidelity simulators. The one on the top left is a task trainer, which teaches people specific skills, such as retroflexion or target practice. The one on the bottom left is a very simple wooden box where they people navigate the scope through the holes. And this is basically designed to teach very basic endoscopic scope handling. There's also lower fidelity simulators for specific tasks. So here there's one on the middle in the top that depicts ERCP task trainer. And although this looks very specific, it's very good at training specific skills related to ERCP. And there's also similar ones for colonoscopy. We also have animal models, which are particularly good for things around polypectomy or bleeding. And then there's the more high fidelity virtual reality computer-based simulators, which are quite expensive. So in looking at all of these simulators, you have to ask kind of how do you actually choose which simulator you're going to use, and cost obviously comes into that decision-making. And there has been initially research from kind of other clinical skills that you could potentially match the simulator to the task that you're doing, and this would allow people to learn the task better. So this is akin to if you're learning to ride a bike. When you start to ride a bike, you don't start on a two-wheeler, you start on a tricycle, and then as you master that, you get training wheels, and you get to take the training wheels off, and then you're on a two-wheeler. So we had carried out a study to look at whether a simulation-based training curriculum that incorporated this progressive task complexity was able to improve performance in the clinical setting as compared to just doing kind of full cases on a simulator. So we had randomized people to two groups. One was the traditional structured curriculum, where they practiced whole cases on a virtual reality simulator for 6 hours, whereas the progressive group went through a series of tasks of increasing complexity and difficulty over the 6-hour period. So they initially started on this very inexpensive low fidelity simulator to master their basic scope handling skills. They then moved on to a virtual reality simulator later, but the teaching was really focused on, again, more basic skills such as loop reduction, tip control. And then they moved on to more complex skills such as polypectomy. And when we looked at this, their clinical performance 2 weeks after training, those in the progressive simulation group had superior clinical performance as rated by blinded as observers. They also had improved communication skills as rated by blinded observers in the clinical setting. And this is likely because they learned the skills at a deeper level, so they were able to pay attention to other things going on in the room, and their teamwork and communication was improved as a result. And this is kind of a visual model to depict the relationship between complexity and learning. So novices generally require less complex tasks so that they're not overwhelmed. Whereas as you gain skills, you require kind of more and more complex tasks to be able to challenge you appropriately. And this relates to something called the optimal challenge point. So it's thought that learners can be, there's a point at which learners are optimally challenged, so they're not overwhelmed and they're not bored. And as people gain skills, you want to change that challenge point. And the progressive learning strategy really allows you to do that, so that you change the challenge point and you make things more challenging and complex as they gain skills. Another simulation strategy that's been deemed beneficial is mastery learning, and it refers to the ability to consistently demonstrate a predefined level of proficiency. So you're meeting a mark before you move on to the next task. And we're going to learn a lot more about this in the second half of the talk, so I'm not going to go into it in depth. So now that I've discussed kind of how to choose a particular simulator, I'm going to discuss some of the other things that we can do in terms of best educational practices to try to make a simulation-based session as effective as possible. So one thing is around feedback, and there's been tons of studies to show that feedback is really the critical component of learning in a simulation-based environment. And if you don't have feedback, you won't learn adequately. So not only should feedback be provided, but it should be provided in the most kind of beneficial and effective way. So one thing that this relates to is the timing of feedback. So we had done a study to look at this, and we had randomized participants to 2 groups. And again, they practiced on this very simple low fidelity simulator. They carried out 15 trials on the simulator, and one group received feedback as they were doing each of the 15 tasks. So there was a teacher there and they were giving them feedback as they were performing the endoscopy tasks. Whereas the other group received terminal feedback. So they didn't receive any feedback as they were doing each trial, but at the end of each trial, they would receive feedback and then they would go on to the next trial. And this just shows kind of the simple simulator that they were working through. And we videotaped their performances, and then we had them do a novel sequence 2 weeks later to see how they could apply their learning. And this graph depicts time to advance. So a quicker time is considered to be more optimal. So those in the terminal feedback group had a quicker time to perform the task. And also based on the blinded expert ratings, they had a more superior performance. So it seems like the terminal feedback group, as opposed to getting constant feedback, was better for learning. So why might this be? Well, one thing it relates to is something called the guidance hypothesis. So we all know feedback helps to guide learners in performing a task. However, if it's provided very frequently, then they often become very dependent on it, so that when it's taken away, their performance falters and they don't know what to do. So it's thought that by providing them less frequent feedback or terminal feedback, it really allows them to work through the problems on their own and learn the tasks at a deeper level, so that when they don't have feedback and they're doing it in a different environment or without close feedback, that they're able to perform better. And one thing that I like to learn use particularly with more senior trainees and with practicing endoscopists is decision training. So this is really trying to get trainees to reflect on their performance. So using key kind of critical challenges during a simulated procedure to have the trainees stop and reflect on what they're doing and talk about kind of the challenges that they're having and what they might do differently, and then for them to decide what they might try and then go ahead and try it. And in this way, you're building in kind of a feedback and reflection throughout the simulation-based practice. Another strategy used in the simulation-based environment is variable practice. So studies have shown that varying the task during training can help to better prepare trainees to handle the wide variety of things that we'll see in the clinical setting. So instead of having trainees practice the same task kind of over and over and over, to vary that slightly so that they're exposed to kind of a broader range of skills and situations. And that has been shown to improve long-term retention of skills. We're also often asked about how do you schedule simulation? So simulation is often scheduled kind of in a course where everything's lumped together in one day, or it can be spread out longitudinally. And research has shown that when you space the practice out, so for example, a half hour over 8 days, as opposed to 4 hours on one day, that's much better for learning because it allows individuals to retain the skills and learn the skills at a deeper level. So finally, I'm going to touch on a few kind of innovative strategies that are being applied to simulation-based training in endoscopy. So as I mentioned, non-technical skills are a really important part of performing endoscopy, and these refer to things such as situational awareness or decision-making, communication, and leadership. So we wanted to look at whether focusing simulation training on non-technical skills, how that affected people's clinical performance when they went to perform the skills in the clinical setting. So we carried out a study looking at the impact of a simulation-based curriculum with dedicated non-technical skills training and whether that improved people's performance in the clinical setting. So again, we randomized people to 2 groups. The first group was the traditional progressive learning group that we had previously, where they worked through tasks of increasing complexity over 5 hours of time. And ahead of that, they had 4 hours of small group teaching and lectures on particular cognitive aspects of endoscopy. And the other half of the participants were randomized to a non-technical skills curriculum. So in this curriculum, during the didactic time, they had a 1-hour session that was focused on teaching non-technical skills. They also reviewed a benchmark video that showed kind of appropriate performance of non-technical skills, and they learned about a non-technical skills checklist. And then throughout the simulation-based training, we made sure that they received feedback that was not only focused on their technical skills, but also on their non-technical skills. And within the integrated scenarios, which I'll touch on shortly, they received non-technical skills feedback and they used that checklist. So within this trial, we embedded what's called an integrated scenario. So this is really a hybrid simulation where we had standardized patients, standardized nurses, and the simulators. And this really enabled the trainees to practice the entire procedure, from taking a history and consent to performing the procedure on the simulator, and then providing the patient with the feedback about their diagnosis after the procedure. And we then once again tested the trainees 2 weeks out on their clinical performance. And as you can see here, those in the non-technical skills group had superior clinical performance, both on technical and non-technical skills. And again, this is likely because they had learned things at a deeper level. And their non-technical skills performance in the integrated scenarios was also superior to the general progressive learning group. So now that we've looked at what evidence exists kind of in regard to novice trainees or training at an individual level, another strategy is around team training. And I would argue that successful high quality endoscopy services really starts with effective teamwork and leadership. And practicing clinicians should implement training for all members of the team so that they know kind of their assigned tasks and can work in a cohesive manner. And as in many other areas of healthcare, teams in endoscopy are constantly changing. So this kind of results in teams of experts rather than expert teams, because you're constantly working with new people. And this kind of teamwork really relies far more heavily on a positive safety attitude, a shared understanding, and an efficient exchange of information. So therefore, it's really paramount that non-technical skills are developed for both the endoscopists themselves, but as well as the broader team members. And collective competence is about working effectively as a member of the team. And it's not about what happens at an individual level, but what happens as a group and how that team can be effective. And within endoscopy, there has been a study by Hurd et al. That looked at kind of team training for nurses and technicians, but this was just done from a perceptions perspective. But there has been research in the surgical literature that actually showed that team training resulted in a 50% reduction in surgical mortality, which is quite significant. A second strategy is just-in-time training. So this is training that's conducted just before an actual clinical scenario. So this is akin to the idea of rehearsing in sports or in music. so that you practice the piano before you go out and do a performance. So I know at our center, we're implementing this with regard to polypectomy. So ahead of people doing a procedure where they have a potential polypectomy, especially for the more novice trainees, we'll have them practice this on the simulator so that when they go out and do the procedure in real life, they've had that practice or that warm up. And the final innovative and potentially applicable educational strategy for endoscopy is around gamification. So this is where you apply game design elements, things like leaderboards or points, to traditionally non-game contexts, such as the simulation-based context. And we're currently in the midst of finalizing a study looking at the integration of gamification into endoscopy simulation-based training. So in summary, your choice of simulators really is dependent on the learning objectives that you have, and you should be matching the simulator to the trainee's developmental level. So if you want to teach very basic tasks, you want to make sure you're using a very low fidelity simulator that's best for training that task. Versus if you want to train bleeding control or polypectomy, you may think of using an anatomical model because those are very appropriate for that task. And it's not always about having the most kind of fancy and technologically advanced simulator. It's often the simpler simulators that are much more effective. You also want to think about feedback during endoscopy simulation and focusing that feedback during the task on essential information as opposed to giving kind of constant feedback, and consider using things like decision training or task variability or space practice to try to enhance learning. And hopefully you'll implement some of the strategies that I talked about, including non-technical skills training, team training, just-in-time training, and gamification. So just before I end, I'd like you to think about something from today's talk that I gave you as to what you'd like to apply to your future simulation training, and just to think of that for yourself and carry that forward. And I'd like to acknowledge my huge number of collaborators, especially Dr. Samira Grover, with whom a lot of this work has been done. And I'm happy to take questions and comments during the panel session.
Thank you, Catherine. That was truly an amazing lecture, and you covered so many important concepts. I'm sure this will generate a lot of questions at our panel discussion. Now we'll jump right into our next lecture, just quite a fascinating topic. Dr. Roy Satigno will be describing the mastery-based approach to endoscopy simulation-based training and how to use simulators for remote endoscopic training. Dr. Satigno?
Hi, everyone. Thank you so much, the WEO, for this opportunity to give a talk on teaching endoscopy using simulators, especially using the virtual training. I have no conflict to disclose. Catherine has already talked about the goals of my part of the lecture. And I would like to begin by stating that we have documented a large variability in ADR. We have documented many things in polyp resections and things like that, that show that we actually have quite a big variations in practice. And the question really is, what do we do about it? How do we fix all of these? If we go globally, as the WEO is doing, the problem actually becomes bigger. There is a significant disparity in endoscopy care. If you're in Southeast Asia, for example, endoscopy may not be available to many parts of the country or the areas, and let alone to talk about the quality. So we've been embarking on the use of simulation for the past 3-4 years. And our vision is really to improve fellows' learning. We wanted to make the part of learning shorter. And we really wanted to make them able and competent in performing by the time they finish training, so that they don't continue the training during their practice. Lastly, in the long run, we wanted them to be able to perform procedure after becoming competent on simulators. There is a major issue here whereby the variations of practice could be partly explained, which is attendings actually cannot learn new techniques very well because most of the training occurs during fellowship. So once you're out of fellowship, you're out of luck, so to speak. Now, if we can have a higher quality, smaller variations, we envision that the endoscopy community will become much more vibrant and the disparity decreases. So let's go into simulation training. So this is a typical simulation training. We do a pre-test, we do didactic, and then we measure the post-test. So in blue here is the pre-test. In orange here is the post-test. And you say, wow, that's good. The p-value is less than 0.001. This must be a good learning for everyone. But then when we ask the experts say, well, if I had to put a minimum passing standard, it would be 80%. So then you kind of like go back to the drawing board and say, well, if you do that, then only about 40% of the participants would have passed the course. So the question then is, how do we deal with that? How do we change the course so that it can lead to almost everyone to pass the standard? And we've been looking at this issue, and we run into the National Academy of Sciences recommendations. It says that if you want to do anything that's of high yield, then you need to use the evidence of learning sciences. This is the best part of a summary of how to use the learning sciences. And I just want to emphasize here that when people look at the essence of training, at the essence of expertise is made really by deliberate practice and feedback. That is the core. Our brain actually becomes smarter as we exercise certain part of it, and it needs to go through this deliberate practice and feedback. What we've been doing in fellowship is perhaps more like didactics, and some simply just doing the fellowship, and those really don't conform to deliberate practice and feedback. So these two things, deliberate practice and feedback, are very important, and I want to just spend 20 seconds to 30 seconds on it, which is to say that deliberate practice actually means a whole lot. Deliberate practice means that we focus the practice on doing rather than knowing. Now, in our giving didactics and things, we focus primarily on knowing, which is easier than focusing on giving, like, how do you make a decision on certain things, which is focusing on doing. And the skills has to be deconstructed. The learners practice step by step, preferably in learning, which is simulation centers. Each step has an increasing difficulty, and the learner must master the previous one before learning the next one. It is effortful and goal-oriented, so this is not an easy thing to do, and you need the expert to give the feedback. At the end, then you put the entire steps together and make it into the skills that you had deconstructed. As the trainee go through this process, they slowly internalize the entire process and make it into a mental representations, so that in the future, when they are meeting things that are slightly different than what they had practiced on, they actually can solve that problem. This is very different than a drill. A drill does not have any of the, or most of these components. So here is the deliberate practice in a diagram, which is to say you go to pre-test, you go to deliberate practice with feedback. This is the master learning when we put it into that framework. And then we have the trainee undergo post-test. Trainees who do not yet pass the post-test will continue the practice. So time is not the limit here. And those who have passed then go on to the next level. Here, by doing this, by doing mastered learning, we can actually ensure that everyone is on the right side of the minimum passing standard. Therefore, we assure competence. So the framework of mastered learning, Catherine has spoken about this briefly, which is to say that mastery learning must contain these 7 components, which is there must be a baseline assessment to understand the gap. There must be a clear learning objectives. And then the core of it is deliberate practice with feedback. The experts determine the minimum passing standards. And as the trainees learn, the coach always assess, trying to see are they meeting the minimum passing standard yet. If not, then the coach will try to guide them so that they can overcome the difficult steps, for example, and then meet the minimum passing standard when they have the post-test. So what should we be teaching in mastery learning? As I had mentioned earlier, it is about doing. We need to be constructing what we do. Technical is easy. You actually can deconstruct technical skills step by step by looking at videos, looking at how the expert is doing. Just be very careful to create the step by step. But knowledge, here the doing of knowledge means that we need to deconstruct the decision making that the expert is doing. So that is a little bit more trickier. We don't have a time to go through it all, but at one point we should talk about that. Now, Catherine also mentioned the importance of using learning theories, and really when we deconstructed the learning theories and then applied to endoscopy, there are many of them. They are certainly way beyond the conscious competence that was described in Peter Cotton's book. So I'm going to spend the next 5 minutes talking about some examples. We have done this simulation-based mastery learning for learning upper endoscopy multiple times. It is now a standard course at our practice at UC San Francisco, and it's also a standard course in some countries in Southeast Asia. So how does it work? So the first step is to have the trainee use a low fidelity simulator. This takes actually about 2 days, whereby they activate their hands and all of their muscles, all the part of the brain that controls those hands. So here the trainee is moving the tip of the endoscope from A to Z on the ball. And in the beginning, it took them about 3 minutes. By the end, you see that their hand is forming very well. And they are able, through focusing on the form, they are able to move from A to Z within less than a minute. The second part of the training, so here it is virtual, so that means that we send the trainee the model. We send them a Koken model, and the trainer has a Koken model as well. And we communicate through WhatsApp and send videos. They send their videos. We talk about their procedures. And now this part has become a standardized upper endoscopy procedure, which is a part of the WEO. And we teach them that. which teach them step by step. We assess them using checklists, and then we measure their outcomes. So here's their scope handling. So as I mentioned, lower value, which is faster, the time to complete from A to Z means better. So you can see that with multiple attempts, they go down in their curve, meaning they become faster, and their speed becomes the speed of the expert. And their hand form is also using all of their fingers. So this is very important, and you can see that this is mastery. How about standard upper endoscopy? Here, after about a day and a half of training, they can perform the WEO standardized upper endoscopy and meeting the mastery standard as well. So in a mastery course, the typical passing is about 97% or so. And here, almost everyone passed in the first trial of the summative assessment. When we followed them over time, they actually perform a lot more of a therapeutic procedure faster. So that's the virtual coaching. Here's how we do it, just superimposing their hands to the trainer's hand. We showed them how to handle the control buttons, the control knobs of the endoscope. They follow it, and they learn it together with their colleagues, and we make sure that we give them the appropriate feedback. We've studied the effect of virtual versus direct coaching on clipping, and we really could not assess any differences in terms of the capability after doing the training virtually. How about training endoscopists who are in practice? So this is face-to-face training using simulations, some in the US and then others in Singapore. And we have the same type of training whereby they undergo online pre-class module, then they undergo the in-class simulation learning that takes about 2 to 3 hours. It's a small group learning, and the results have been amazing. So here you can see that before training, that is in the light blue curve, they actually were not practicing the use of over-the-scope clip. So after the course, then about 50% in Singapore and about 75% in the US immediately started to practice. So for years, they have had the accessory available, but they were not using it. With one course, then about 50% to 75% of the participants started using it in situations like upper GI bleeding. The evaluations of SBML course have usually been very, very good. And here we also have confirmed that the use of the knowledge tend to be sustained. Here we showed that the accessory, the over-the-scope clip, was used about 2.5 times more after a course in the unit in the United States. What about teaching cognitive knowledge? And here I want to just share with you this brief video, just about 2 minutes, to share with you that this is not all of this is not our ideas,
but
this is
view that really
part of
even the last century there's been no innovation or no real change?
I mean, there's been some change, but fundamentally it's being taught like it was, with the wise man standing up, spreading knowledge to the students. And that was necessary before you had the printing press. It was the only way to spread information, but it kind of became obsolete. We haven't quite adjusted to the improvement over that technology. So let's say I was teaching you the basic ideas of electricity. In the classic lecture, you'd be sitting there listening, and I'd tell you all of this formalism and all of these technical terms of voltage and current and amperage and resistance and conductivity and so on. That's the classic. Start with the first question myself. I get it all the time, usually from some gray-haired physics professor in the front row, is, well, you're saying all these traditional lectures are so bad, but how can that possibly be? Look at how great I was, and I just learned from traditional lectures or at Nobel laureate. And the response that I have to that is that it was exactly this same reasoning that justified bloodletting as the medical treatment of choice for 2,000 years. And the lecture is just the pedagogical equivalent of bloodletting.
I'd like you to describe your flavor of active learning.
My flavor of active learning isn't Carl Wyman's. It's Carl Wyman and 500 other researchers who do the same kinds of things I do. It's something like 1,000 studies comparing the standard lecture method, with the same population.
So what I wanted to share with you with that video is that what we have been doing and what outside endoscopy are doing is very different. And here we have Professor Wyman, who is a Nobel Prize winner, talking about that this new way of learning is really not one person's idea. It is like at least 1,000 papers are out there. And some of these things is about the use of mastery learning. None of this thing is just is like Catherine's ideas, Roy's ideas. No, this is actually what's out there outside endoscopy. So going back to how to incorporate knowledge in teaching, here are the simulators. When we teach knowledge, the simulators are actually cases that teaches people on the deliberate practice of doing. So here the emphasis is doing, because we typically teach people of what is knowing. So this graph is actually a true graph. This is part of us teaching mastery learning of hereditary colon cancer. And here we actually showed that most of the participants, this is by the work mostly by Sylvia Sanduliano, that we can achieve all of the participants passing the minimum standards through a mastery learning curriculum. I have many people to acknowledge of our endeavor into mastery learning and experts science, Carl Wyman, William McGehee from Northwestern, and from our group, Tonya, Ravi, Sylvia, the Academy of Endoscopy, and this is how we've been practicing and learning ourselves on how to go into a brand new area of the science of expertise and education science. So thank you very much. I urge all of you to go look at these references. If you can, please read this fascinating and beautiful book, Peak. You will be enticed about how deliberate practice should happen. And then Mastery Learning, a book by William McGehee. Thank you very much.
Thank you for that wonderful lecture, Dr. Sutikno. It seems like, this is definitely the way to go. And there's so much evidence on how to use simulators and evidence for durability of learning, and both from Catherine's lecture and your lecture. And, it's still surprising to me that we continue to use simulators more as a supplement rather than using it as the way to teach. endoscopy and technical and non-technical skills. So now we'll start our panel discussion. We have 4 panelists, including myself. We have Dr. Walsh, Dr. Satikno, Dr. Cohen, and myself. And just a reminder, any of you watching who have any questions, please type it in the Q&A box, and I'll ask the questions on your behalf. But to just get this started, anyone in the panel, it seems like, there's lots of evidence on a standardized approach and deconstructing tasks and how to progress from novice to expert when you design a simulator-based curriculum. I just wonder, because trainees learn at different pace, and they may be, one may be very quick to grasp basic skills and need help with certain skills. Should simulator-based training be more customized to the trainee rather than, have a standardized curriculum that fits all?
I think that's the beauty of the mastery learning, because in mastery learning, the limiting factor is really having everyone become a master. So time there is not the essence. And here we actually accommodate the variations in the speed of learning, so to speak, through the curriculum itself.
I was just going to add that. Go ahead, Catherine.
Oh, sorry. I was just going to agree. And I think you can build not only mastery assessments kind of at the end of an entire skill, but you can embed them kind of throughout the training so that you have kind of benchmarks along the way. And you don't move on to kind of the next skill until you've mastered the earlier skill, as opposed to necessarily waiting till the end. And that will also help to tailor education to the trainee.
Thank you, John.
So I was going to add something, and it's kind of it's a little bit of a promo for the 3rd seminar on assessment. But I mean, critical to the process of giving feedback in deliberative practice is ongoing, formative, assessment that will see what are the areas that some individual needs to then deliberately focus their training on. So it's not just that the teacher has an active role as a curator to assess and help them create the next lesson plan of what to work on, and it's an ongoing iterative process, and that's what makes it learn faster. I was going to ask Roy about what he thinks that we can learn from artificial intelligence and the way machine learning is occurring. Will it help humans learn? Can AI help HI?
I think there is a potential for that, but I think we have to see. It is not clear to me if the AI is always right, for example. What if this AI is telling people, look at this half of this flat polyp, and that's your flat polyp, rather than the entire flat polyp, which some people are seeing in their AI. That would be horrendous, I think. So I think there's much to be learned about this AI. I personally don't believe that I will be living in a world whereby I will be controlled by a computer. That would be a sad thing for me. So I rather work on the simulation-based learning and make everybody to be better than the computer.
Thank you. I have, those were some good responses. I think, you need combination of standardized curriculum and then maybe tailor certain simulator-based sessions based on the trainees' needs. Now, I have a question about, we just heard about feedback. Now, what's the role of a mentor present completely during the session? I ask this because we have these virtual reality simulators. They're expensive, but they're available, and they give you kind of this automatic machine-generated feedback, based on, for example, the resistance that the trainee uses, again, which is measured by the simulator, versus more nuanced feedback from the mentor present throughout this session.
Yeah, so I think some simulators are capable of giving feedback, like the virtual reality computer-based ones. we did do a study looking at that, and those who had an expert mentor there had far superior learning than just relying on those metrics. I think a lot of the simulators don't necessarily provide feedback in the same way. Some of the more basic task trainers and the anatomical models. And I think it's extremely important to have somebody there across kind of any skill. Feedback and practice, as was pointed out, are kind of the two key ingredients to successful learning. And you really need somebody there with a keen observational eye who's looking exactly kind of what's going on and focusing so that they can provide feedback to help improve performance.
Thank you, Kev.
If I can just spend 20 seconds on that. Remember, we talked about this deliberate practice part, whereby there's deliberate practice and feedback as the core component. And the result of doing this is that we create a mental representation of the process. So the role of the coach here is really to give coaching that will guide the learner so that at the end, they develop the mental representation of the process.
John, you were saying? Thank you, Roy.
Yeah, just, a little bit just more on that idea about, I'm thinking about the on a simulator, an ex vivo simulator or whatever simulator, you see the pictures that Roy showed. There's a little group and they're spending 2 hours, but the people who are not with the scope, they have to be actively engaged. And I think it's interesting with this active learning. The teacher is giving feedback, but so are the other participants. And I think it really brings out the if the group is trying to figure out how the members of the group are doing, give themselves feedback, and then you have a teacher who is also there present. I think it really accelerates, makes it more fun, it makes it more engaging, and I think that's that active learning that I was talking about. But given that, I wonder, Roy, this idea of a virtual mentor versus a present mentor there. I don't know if a virtual mentor can be that engaged with a group and the person doing the, so I'm just skeptical whether or not a virtual mentor equals a present mentor. Maybe Roy or Catherine can comment on that.
Catherine, go ahead.
So I think they potentially can. I think you have to have the right setup, right? So you have to have a proper view so that they're clearly kind of seeing what's going on, and appropriate audio visual so that there is clear interaction. And I think as Roy had depicted some of the images where you're actually directly kind of comparing how they're doing it and how you're doing it. So I think it does rely on the appropriate technology, but I do think that you can provide feedback virtually.
I think the virtual is not only like almost like a gimmick, I would say, but what we found is that the virtual part is actually a necessity. For example, you're trying to teach a group of people a very complex skills. Like how do you like manipulate the tip of an endoscope and get to the point of a master at the end? That's a very complex things. I don't know if you guys remember, it would take us months during our fellowships just learning these. That's a hard thing to do, but here, because the process is prolonged, we cannot be doing this face-to-face with them. So we actually need this virtual part. The same thing with the experience that Sofia had, teaching hereditary colon cancer, detection, recognition of it. That's a very complex topic. Yeah, you cannot be doing a face-to-face that would take like 3 days on this one topic. So the virtual actually allows you, the technology allows you to be doing this.
Thank you. And just to clarify, when you do the virtual mentoring session, are you watching a single trainee or a group of trainees live through the performance? I mean, through their session? So
like, for example, in July, we are going to have a course in upper endoscopy for the first year fellow at the UCSF. It's now a mandatory course. And they have 3 hospitals. There'll be about 4 rooms there. So the coach really goes from one room to another room to another room. Maybe at one point, the coach then broadcasts to everyone. But then during the day-to-day, the coach just move from one room to another room to another room, just like using your Zoom. Yeah.
That's great. And related point, I think you mentioned videotaping the performance as they do in sports, and that's a more powerful way to give feedback, because we've all been there when we try to give feedback and about a specific component of a skill, the trainee is not able to relate to it. How realistic is this in real life to videotape trainees? And each of you can comment, and especially the virtual mentoring, can that be used? They videotape their session, and at the trainer, their own time or their free time, they can review and give feedback.
Catherine?
I'll take that first, Roy.
Oh, me first. The principle of feedback, I think if you summarize it, are 4 things. Okay. Number 1, it has to be timely. Number 2, it has to be very specific. Number 3 is that it has to be non-threatening. And the last one is actionable. So here, Catherine talked a little bit about when to give the feedback in terms of time. And she said, well, if you give it at the end of it. Okay, so that tells me that there's an importance to give it at the end as opposed to a week later. So I think if she had done a study of like at the end versus a week later, I would say that a week later will not be timely. So it would not be very good. So there is some components of limitations of videotaping.
Yeah, you can, I know not in endoscopy, but in other contexts in our hospital, we will use like an iPad just to video things and then can quickly kind of go through the video with the trainees. It does definitely, it's a skill set that you have to learn as a teacher in terms of how to integrate that into your feedback or debriefing after a simulation-based session. There has been some research to show that it may help give learners kind of better insight into their own performance and help enhance their self-assessment ability. But it can be difficult, or the feasibility can be an issue in terms of doing it in real time. And I agree that this should not be done like a week later. If you're going to do it, it should be done at the time and done with kind of an appropriate platform.
Okay. And John, I want to ask you a related question. Often, you've done a lot of these simulator-based courses, and trainees usually have lots and lots of questions. And as trainers, we have lots of comments, and it's tempting to give feedback. But sometimes that creates, interruptions, and we just heard terminal feedback, is more effective. So how do you handle that? When you have, lots of comments that you feel are important to convey, do you write them down, or do you ask the trainee to hold on to their questions? How does one handle that as a teacher?
Well, I mean, imagine a group. You have 5 people in a group and you're working on a skill. I think one of the things is you really have to limit what you're trying to achieve at a given time, and really focus in on fewer techniques rather than trying to get everything in. And if you're doing that, I think that you can ask the group, we're going to watch this person do this, and let's take some notes, have someone be the scribe. And they can write them down, then go back and it's part of the exercise, where the feedback's going to be. So it's an active process of a number of eyes observing, and then going back, and that's part of the actual. The other problem in practical terms is not leaving enough time for this. Everyone wants to have their hands-on maximal time playing around with the scope, but you have to leave in time for these assessments and feedback as the sort of the more important part of the learning to some extent. And you have to, since you also have enough time to actually practice and get it wrong, since some people learn by not by seeing or by hearing, but actually by doing and getting it wrong and fixing it. So I think that you've got to have the time management is very important to allow time for all this stuff. Whether you interrupt them while they're doing it, you can't keep doing that all the time, but I think certain things you could say, aha, did you just do something right or wrong there? And then you can actually make them stop, think about what they just did. And again, it's the same thing as doing it in real endoscopy training, stopping and focusing on something. Otherwise, but if you keep chiming in different things while they're doing something, they will not learn anything. There'll be cognitive overload.
Yeah, and I was just going to make a comment in terms of the terminal feedback. So the study that we did, it was a very simple task, and the tasks were it took them kind of 1 to 2 minutes to do. If you're training a much longer procedure, then you may have to stop and talk to them and have that feedback conversation. But it's the idea of like not constantly talking over them and providing feedback as they're trying to perform the task. But when you do provide feedback, as John had mentioned, to have them stop and reflect on their own performance and try to get them to come up with kind of what the issues are and what the solutions are.
Thank you. I think personally, I think that's been one of the most important things I've learned from these courses, because we have all these wonderful ways to teach, but, to avoid this cognitive overload, how to give the best, most effective feedback. So I think that really brings out the most value out of these sessions. We have a minute or two. Anyone in the audience, if you have any question at all, we do have a question. So this is specifically to Dr. Walsh. You mentioned about just-in-time training for learning skills before doing a specific skill on a patient. How do you plan that, and what kind of setup do you recommend in the endoscopy unit to achieve this? So, Catherine.
Yeah, so I'm actually in the pediatric context. So usually these procedures are where we have a patient with kind of rectal bleeding, and it's a younger patient without other signs and symptoms. So we're suspecting a juvenile polyp. So we just have kind of a small room where we do our capsule studies, where we have this simulator set up, and the trainee can come in just ahead of the procedure and do the just-in-time training. I think in the adult context, if your trainee's doing, for example, a screening list, they may likely encounter a polyp kind of during that day. So ahead of kind of the endoscopy list for that day, they could do a quick warm up on the simulator. But we have this both in our endoscopy suite, and I know at our hospital, they use it in the Emerge, where they have a room with different kind of procedural simulators. And the trainees can go in and use them ahead of when they think they'll have that type of procedure.
Great, thanks. I mean, there's so many questions, and it'd be wonderful to continue this discussion, but I think we are out of time for today's webinar. I just wanted to thank all of you for an excellent session, very thought-provoking, and for the audience, this will be recorded and available on YouTube to watch later. And again, want to thank all of you and the WEO for helping us put together this series. So I just wanted to go a couple of things to watch out for. We do have the third webinar as part of the series sometime in September, October 2022. This will be primarily on assessment of competencies and feedback. So look out for that in the near future. And also wanted to mention upcoming WEO webinars on July 15th. We have a laparoscopic endoscopic collaborative surgery webinar. And you have this QR code to register. Please complete this feedback survey. We really learn a lot and can improve further with your feedback. And I would encourage all of you to provide your email and your full name, and so we can kind of keep in touch, for future programs. And you'll also be able to receive a handout and some important articles that cover the core material. So if you provide your email, it'd be very helpful for that. So thank you all again. And any closing comments from our faculty? Thanks again. Dr. Walsh, Dr. Sutikno, Dr. Cohen, thank you.
Well, I want to thank you, Vignesh, for running this this great session. And I figure the focusing is not cognitive overload, but lesson overload. I really got some great lessons from this about the idea about just what deliberative practice is, and also this idea of I just watched they do it in other industries. We learn from aviation industry. We the military plans. They plan out what they're going to do, and they give feedback, and they use simulation. So we should learn from others, as Roy has done so much in his career in terms of looking from educational theory, but there's a lot that we should do to not reinvent the wheel.
Yeah, absolutely. Absolutely. Yep. I learned a lot, and thanks again, everybody. Have a wonderful day. And thank you all for watching.
Thank you.
Thank you.
We'll conclude this session. Thank you, everybody. Bye-bye.